going to talk to us about musculoskeletal infections associated with trauma. So Olivia, without further ado, Dr. Rice.
All right, thanks everyone. As Dr. Pat said, my name is Olivia Rice. I'm a current PGY2, and I'm going to be talking to you guys about diagnosis and treatment of fracture-related infection. So unfortunately, as many of you probably know, treating surgical site infections are troublesome for all parties involved. So as surgeons, we like to operate on patients in order to improve their overall function and improve their lives. And so when you run into issues like infection, it can be especially troublesome. And even when the diagnosis is clinically obvious, as seen in this photo here, it's treatment and diagnosis are often very time consuming, and thereby definitely can be disheartening if unsuccessful. And so fracture-related infection is a little bit of a different animal relative to other surgical site infections, mainly because the balance of stability and infection eradication are often at odds. And what I mean by this is when a patient presents with a fracture, there's obviously loss of inherent stability of the limb. And while a lot of the elective surgical procedures that we perform in orthopedics, we may make the limb slightly more unstable initially with surgery. Typically doesn't have the same amount of soft tissue damage and bone damage as a fracture does when it presents. Additionally, we have a little bit more limited ability to optimize our patients preoperatively. And likely due to its diverse presentation, fracture-related infection goes by many names. And it's hard to improve the treatment and diagnosis of a problem that's not referred to or published consistently using the same terminology. And so just in the past few weeks, as I dove deep into the literature on this topic, these are just some of the names that I came across referring to a fracture-related infection seen here. Similar to the inconsistent naming conventions, fracture-related infection lacked a standardized diagnostic criteria up until about 2018. And this is just a systematic review that looked at all the different fracture-related infection randomized controlled trials, anything to do with infection and fracture, or infection after operative fixation of a fracture between 1985 and 2015, and found that 70% of them didn't even define what they meant by infection, even though it was listed as a major outcome parameter within the results section. And only 2 studies listed a formal definition, such as CDC's surgical site infection criteria. Sorry about that, 1 second. Okay, and so just to go over the CDC criteria very quickly, this is just the definition according to CDC, which has changed a few different times, but the superficial incisional infection is diagnosed, obviously included within the skin or the subcutaneous tissue, and then typically does not have to be treated with any type of deep invasive procedure. It must be within 30 days from the date of surgery. Then there's the deep incisional surgical site infection, which involves the muscle and fascia, and has to be diagnosed within 90 days of infection for any orthopedic related procedure. Finally, there's this organ space or bone infection, which is where technically osteomyelitis falls. And this can be seen, osteomyelitis is sort of a tricky word to begin with, just because it is sort of vague technically, and really just means inflammation of the bone. And so this has to also be diagnosed within 90 days of infection. But as we know, that osteomyelitis can come from a variety of etiologies, so this can be a little confusing when researching the literature. So this led to the definition a fracture-related infection as described by the International Consensus Group for musculoskeletal-related infection, and which we'll go through this diagnostic algorithm here. And prevention, diagnosis, and treatment can really sort of be a spectrum of care here. And so we're just going to go through a case quickly to sort of demonstrate some of the different aspects of care. So this is a 20-year-old male with a closed segmental tibia fracture that presented over the weekend on call. And so initially, we want to talk about prevention of infection, as prevention is often a lot of times easier than a cure. And so even in the setting of a closed fracture, there's still significant things that we can do in terms of preventing infection in any type of fractures. And part of this has to do with the bacterial load and the virulence of that bacteria. And so from a bunch of different studies, basically we know that preoperative antibiotics are crucial here. And while Castillo is popularized for his open fracture classification, he actually really initiated this idea that preoperative antibiotics, more than postoperative antibiotics, for example, are really beneficial in preventing any type of surgical site infection, especially in open fractures. And bacterial virulence is also worth noting here. The AAOS clinical practice guidelines note that the duration of hospital stay is a significant factor associated with increased risk of surgical site infection. On the same list, the only other factors on there are really patient-specific, more so regarding to this host predisposition variable seen in the equation. But hospital duration of stay is something that's within our circle of influence, both as a system and as a surgeon. And so something that we could definitely improve on. Additionally, a systematic review looking at the effectiveness of intervention with MRSA decolonization and prophylaxis in cardiac and orthopedic surgery operations showed that preoperative prophylaxis with just general broad spectrum antibiotics like vancomycin when given to everybody was not protective against gram-positive surgical site infections, but a bundled payment that both screened for the patient for MRSA and then prophylaxed or decolonized them. Only the patients that were specific for MRSA was actually significantly protective against gram-positive surgical site infections. And so finally, host predisposition, like I said, in trauma is a little bit more difficult to address directly, although we do know based off of some prospective studies that, for example, optimizing patients' overall wellness by looking at pulmonary contusions, monitoring lactate, working with our trauma colleagues, that type of thing is definitely beneficial in terms of patient-related outcomes. And obviously, just based off of medical comorbidities, not every patient is going to be equal in this sense. And so one of the other things I just wanted to mention was host defense, which I think as a surgeon we can contribute to slightly, and primarily through decreased invasiveness of the surgery involved. And so this study from the quality database showed that there was significantly lower rates of postoperative surgical site infections while in non-orthopedic related procedures, but still pretty impressive results there. And it was good because they used these specific surgeries because they were established both in the minimally invasive and the open approaches, and the open approaches didn't only have to be used for more extensive disease. It was mainly based off of surgeon preference. And they still found that the minimally invasive aspect of the surgery alone is decreased the overall postoperative surgical site infection risk. So back to our case, this patient was a young, healthy male, basically got admitted for a few days and fixed over the weekend. It was provisionally reduced using this plate here, which was removed before closure. About a month later, he comes into clinic and he's doing pretty well postoperatively. He does mention though that he had some facial fractures at the time of injury, which were fixed by the plastics team, and he actually ended up developing a fistula in his mouth, and with a resulting infection, and had to be debrided intraoperatively, and was on a week of IV antibiotics, but then transitioned to oral based on sensitivities of culture. And so, as you might expect, within a month, the patient comes back with a draining sinus of his tibia as well. So here we'll discuss the International Consensus Group's fracture-related infection definition, which involves diagnostic criteria. So 5 confirmatory criteria, meaning the patient definitely has an infection, include both clinical and laboratory findings. So the clinical findings involve a fistula, sinus, or wound breakdown, which was seen in our case patient, as well as purulent drainage from the wound, either preoperatively or intraoperatively. And these confirmatory criteria were actually based off of a couple different systematic reviews looking at the common clinical signs and symptoms of fracture-related infection. The confirmatory criteria were the only 2 things that were consistently seen across all of the different studies that they reviewed. Although, as I mentioned, all of these studies lacked a standardized definition of what fracture-related infection is. So it definitely may continue to be updated as we use a more standardized definition of fracture-related infection. But the suggestive criteria you can see to the right are definitely things that we think of in terms of clinical signs and symptoms of infection, including warmth, fever, systemic signs of infection, which can also be, I guess, clues that the patient could be infected, but are also sometimes seen in normal postoperative courses as well. And so in regards to those suggestive criteria, there's, we obviously like to use and note that laboratory values can be helpful in terms of working the patient up for a diagnosis of infection. And so the AAOS surgical site infection clinical practice guidelines found that based on all the evidence available, there's strong evidence to support C-reactive protein to rule in or out patients with suspected infection. Keep in mind, though, the CPG clinical practice guidelines are primarily based off of the CDC's criteria of surgical site infection. They did include studies up until a year, I believe, that qualified infection up to a year after surgery, but most of the studies have to do with the acute infection. However, Tornetta and colleagues also found that the use of white blood cell count, CRP, and ESR were cumulatively predictive and helpful in terms of diagnosing the preoperative infection in patients with non-union. Recently, however, there's a systematic review that basically just said in terms of CRP, it can be useful to aid in working up the patient for diagnosis of infection, but it is not confirmatory for the diagnosis of infection, which I think is fairly reasonable. And so after, if you get to the point where you think surgical exploration is warranted, a lot of the times I think we have a pretty good hunch that the patient is infected. And so in order to confirm the diagnosis, we typically use intraoperative specimen deep tissue cultures, especially along any type of implant that's in the patient. And so these, the last 3 of the 5 confirmatory criteria have to do with laboratory or deep tissue culture results. And so one thing that is worth noting is there is specific criteria that at least 2 separate tissue specimen have to be positive, and they have to be like single isolated organisms on culture to qualify for this fracture-related infection criteria. And alternatively, the presence of microorganisms by staining techniques, not necessarily gram stain, which they said is, if positive, can be helpful, but like many of these things, if negative, it's not necessarily good to rule out infection. But things like the staining for tuberculosis and fungi are useful in this setting, although not nearly as common as bacterial infections. And additionally, just recently, the presence of histopathological examination of white blood cells or PMNs under a high-powered field has been added primarily for use of diagnosis in chronic infection. And again, with AOS's systematic or clinical practice guidelines, there's strong evidence to suggest using culture. That's obviously been our gold standard diagnostic tool for infection for years. And as I mentioned, like most things with confirmatory criteria, which are specific, meaning that they are useful to rule in, most of them are not useful to rule out infection, meaning if those things are negative on your examination, you can't reliably use that absence to rule out infection. However, this is where the quantitative histology of the white blood cells on the high power field may come into play, as a recent study by Morgenstern showed that when used as a bimodal, in a bimodal or binary fashion, this can be used to essentially say if more than the 5 PMNs per high power field are present, this is pretty specific with a positive predictive value of 100% for an infected non-union, whereas if no white blood cells per high power field are present, then this is predictive with a positive predictive value for aseptic non-union of 98%. And for this reason, this is why the international consensus team decided to add this to the confirmatory diagnostic criteria. So the patient came in with a fistula. So we know based off of the new standardized definition of fracture-related infection that we believe he has a fracture-related infection. And so we take him back to the operating room, and there's 4 different sort of fairly common treatment strategies that have been popularized primarily by the total joints literature. And first we'll start with the earliest and simplest, which is hardware retention and irrigation and debridement. And so a bunch of the attendings out of this institution actually contributed to a paper regarding the maintenance of hardware after early postoperative infection. And it seems like based on this study and others that the use of maintenance of hardware and irrigation and debridement and isolation is really useful for the early postoperative infection. And I think the number that is typically used is less than 4 weeks. And this is obviously in a setting where the fracture is not healed yet and hasn't been given time to heal yet. Next is the single stage exchange. And this is often or also used in the setting of an unstable fracture where just removing the hardware wouldn't be possible. And the 1 versus 2 stage exchange is sort of dependent on host factors, as well as just the status of fracture healing, as well as the resources of the surgeon and the institution involved in care. But one thing to keep in mind during the 1 stage or 2 stage exchange is that the use of local antibiotic prophylaxis, especially regarding antibiotic cement, has been shown to be beneficial regarding the infection eradication success rate. And so the 2 stage exchange, as I mentioned, is an alternative to the 1 stage exchange and sort of depends on both the situation of the patient and the extent of the infection. So one example of a 2 stage exchange is segmental bone resection and placement of a circular fixator for distraction osteogenesis. And so the graph seen below is a study that basically is another fracture-related infection consensus paper that just gives sort of the breakdown of both antibiotic treatment systemically and these different surgical treatment strategies in terms of what the patient's situation is. And so obviously if the fracture is healed, hardware removal is definitely the easiest treatment. So this patient this patient was treated with an antibiotic-coated nail He was about 2 months post-op, and so a little bit too late in terms of in order to have a good success rate for just hardware retention and irrigation and debridement. And so just again, to reiterate, the treatment also involves antibiotics as well as surgery. And so getting the infectious disease colleagues involved early is definitely beneficial. And there is a few different controversial topics worth noting here. One is the use of systemic antibiotics in the setting of culture yield, especially chronic infection. And while I think it seems like the literature is consistent in that it's recommended, especially in the chronic setting, to have a period of antibiotic-free time, meaning the patient isn't taking oral antibiotics or isn't on systemic IV antibiotics for 2 weeks prior to the surgery. However, an area of a little bit more controversy is the use of preoperative antibiotics immediately prior to incision. And so this just has to be weighed against the risk of postoperative infection, because with every surgery, there is risk of introducing a new infection as well. And there are some studies to suggest that the risk of a postoperative infection in a patient that's already being treated for an infection is significantly higher. And so holding these preoperative antibiotics in that sense can put the patient at greater risk for postoperative surgical site infection, in addition to the risk that they already have. And so the general recommendation now is to hold the preoperative antibiotics and give them right after the tissue is obtained for culture. However, this just needs to be weighed against the risk of surgical site infection after surgery. And so then there's the PO versus oral antibiotics debate, which seems to be less of a debate as time goes on. But there's the pretty well-known Olivia trial, which compared the oral versus IV antibiotics for bone and joint infection. And this showed that oral antibiotics were non-inferior to intravenous antibiotics for the treatment of any type of deep bone or soft tissue infection. And this led to the International Consensus Group for fracture-related infection recommending that IV antibiotics can be switched to appropriate oral agents if applicable based on tissue sensitivities, and that combining the treatment care plan with our infectious disease colleagues is definitely helpful. And they basically said that the prior recommendation of the 2-week IV antibiotic therapy can be abandoned. So just in terms of takeaways and what I hope you learned from this talk, hold strong with infection prevention. I think we're continuing to show that the surgical site or the surgical checklist, preoperatively making sure that patients get antibiotics in the emergency room, especially with open fractures and within 30 minutes of their incision, is definitely lowering postoperative infection rates. And so the more that we prevent, the less we have to treat. And I'd also encourage using the consensus definition for fracture-related infection, both when talking to patients, colleagues, and when reporting infectious complications of fractures in the literature. And just to remember that the confirmatory criteria is the purulent drainage or the wound breakdown of the fistula, and microorganisms identified on tissue culture or histopathological exam. And the suggestive criteria should be used to augment your clinical judgment, but cannot effectively rule in or out fracture-related infection. In terms of the treatment strategy, this consists of performing surgery and giving systemic antibiotics. The 4 common treatment surgical strategies is hardware retention, 1 or 2 stage exchange of hardware, and also just removing the hardware if the fracture is healed. And this is combined with systemic antibiotics, which just to keep in mind, if the patient does get has another diagnostic criteria for fracture-related infections, such as a draining fistula or sinus, the current recommendation is to continue treatment with antibiotics, even if they are culture negative, since they technically qualify for a confirmatory fracture-related infection based off of other clinical signs and symptoms, even if their culture is negative. And at this point, most are recommending that PO is equivalent or non-inferior to IV antibiotics, permitting culture sensitivities from the patient. And the risk benefit of holding the preoperative antibiotics needs to be weighed against the potential slight loss in culture yield, especially in the chronic setting. A special thank you to a few individuals who helped me prepare and review for this talk. Thank you.
Thanks, Olivia. Great review of all that. I would, obviously we have a bunch of infection experts, trauma surgeons online to help us through this. One of the questions that I had that may be a little bit tangential to the specifics of your topic, but interested to see if you know anything about this, or in talking with Dr. Shu, in terms of quality for our department, how is quality assessed on the fracture side in terms of infection rates? Do we know, do they classify the closed fractures different from open fractures? Is the data granular enough to be able to do that? Hopefully, yeah, there's Dr. Shu, he's on, and maybe he could help with this answer. But does that make sense? Sort of looking at, we know in joint arthroplasty, we have, certain standards and benchmarks set. It would seem that in this population, as you alluded to in your talk, time after time, there's a lot more variability in what we're looking at and what we experience. Any thoughts on that from your standpoint, and maybe a secondary answer from Dr. Shu?
Yeah, I'll give it a shot, and then Dr. Shu can feel free to chime in. I think the open versus closed distinction, there is different coding criteria for open versus closed fracture, but obviously most of the quality data is dependent on surgical or on coding, which we know can be inconsistent. And so that is something that is sort of non-perfect about the system, and just in terms of having to rely on the coding data. I don't know how granular the quality dashboard gets. Dr. Shu, do you want to comment on that?
Yeah, the most important thing with risk stratification for that is documenting not only the severity of the injury, but the patient's comorbidities probably actually have the biggest impact. So other injuries, comorbidities, risk factors, social factors like smoking, et cetera, they put you in a little different higher category as far as length of stay and readmission rates, because we're benchmarked against national standards that are weighted based on comorbidity. And the biggest challenge that we have a lot of times is we don't have those things documented very well. And they have to be documented during the initial admission. They don't necessarily have to be on the H&P, but while the patient's in the hospital the first time. The other thing to kind of win the game a little bit when it comes to these fracture-related infections or readmissions is if they come in, usually the open fractures are not treated same day and out on OBS, but you potentially get more than one day on OBS for certain patients. Our trauma critical care service doesn't really admit to OBS, but if you have a readmission for a fracture-related infection, you could admit them to observation rather than inpatient, because the nationally reported data is inpatient to inpatient. So even if their index procedure is inpatient, if their subsequent procedure is outpatient, it disappears from that quality metric.
Sure. I was pausing because I thought Dr. Karenacher had a question.